Welcome. We're here today to really unpack some essential calculations, stuff that's absolutely fundamental for anyone in radiation oncology, especially residents, maybe, navigating physics training or prepping for exams.
Exactly. We're going to dive into the numbers behind things like physical and dynamic wedges, also the tricky business of matching adjacent
Yes.
fields.
And electron beams too, right? Their dosimetry.
Yes, electron beams, and also how we handle the fact that, well, patients aren't just blocks of water. We need to account for tissue and homogeneities.
Okay, so we're sort of building on the basics people already know, like monitor unit calcs for open fields, PDD, TMR, that kind of thing.
That's the idea. We're moving into these more complex, but really, really common scenarios you see every day. And mastering these isn't just about exams.
No, it's critical for safe treatment.
Absolutely, for
Okay.
accuracy and safety in the clinic.
Okay, let's roll up our sleeves then. We've got some great material here to help solidify understanding. The goal really is to give you the tools and maybe the conceptual framework to tackle these calculations confidently.
Both on paper and when you're looking at a plan on the treatment planning system, the TPS.
It's about understanding the why, not just memorizing formulas.
Exactly. When the physics principles make sense, the calculations become intuitive.
So first up, wedges.
Yeah.
Physical wedges. These big, heavy metal things we slide into the beam. Why? What are they actually doing for us?
That's a perfect place to start. The fundamental reason we use a physical wedge is to modify the beam's intensity across the field. Specifically, it's designed to tilt the isodose lines.
Tilt the lines.
Yeah, think about a standard open beam. The isodose lines, those lines of equal dose, are generally pretty flat, maybe curving a bit near the edges, like layers, as you said.
Right.
But if you're treating with multiple beams angled towards each other, maybe like non-opposed beams for a deep tumor.
Pelvis or head and neck, maybe.
Exactly, those cases. Where those beams cross, the relatively flat dose distributions from each beam just pile up. You get a high-dose region, a hot spot, often right in the middle where the beams overlap most intensely.
And you don't necessarily want that peak dose right there.
Not always, no.
Ah.
So the wedge is used to counteract that pileup. We orient it so the thin edge of the wedge points towards the area where the beams overlap most, where the hot spot would form. The thick edge points away from that.
Because the thick part attenuates more.
Precisely. The wedge is dense metal, right? It blocks more radiation where it's thick and less where it's thin. This creates a gradient, a slope in the dose across the field underneath the wedge.
So it's like deliberately making the dose uneven across that single field.
In a controlled way, yes. It scoops out some dose from under the thick side, tilting those isodose lines. Now, when you combine two angled beams, each with a wedge oriented correctly.
The tilted lines add up differently.
Exactly. They combine to create a much more uniform, homogeneous dose distribution across the whole target volume. It smooths things out and avoids those really intense central hotspots.
Okay, so they're vital tools for dose shaping, especially with angled beams. Now, obviously, sticking a chunk of metal in the beam, that's going to reduce the radiation getting through, right? How does that mess with our monitor unit calculations?
It absolutely does, and that's the core of the calculation part. The main way we account for this is using something called the wedge transmission factor, or just WF.
WF, got it.
The WF is simply a ratio. It's the dose measured at a specific point with the wedge in the beam, divided by the dose measured at the exact same point under identical conditions, but without the wedge, just the open field.
So it's basically telling you what fraction of the dose gets through the wedge compared to an open beam.
Precisely. And since the wedge always attenuates, it always blocks some radiation.
The dose with the wedge is always less.
Always less than the open field dose, which means the WF is always a number less than 1.0, maybe 0.7, 0.65, something like that.
Okay, that makes sense. And if the wedge is cutting down the dose, reaching my calculation point, logically I need to run the beam for longer, use more monitor units to get the prescribed dose there.
That is the absolute key takeaway. You have to compensate for that attenuation. So you calculate the monitor units you would need for the open field first, using your PDD or TMR or whatever method.
Wait, the standard calculation.
Then you take that number, the MUS for the open field, and you divide it by the wedge factor.
Divide by the WF. Okay, so the formula looks like MU with wedge equals MU open divided by WF.
That's it. Let's walk through a quick example, like the one in the source material. Say your open field calculation gives you 150 monitor units needed for the prescribed dose.
Okay, 150 MU open.
Now you add let's say a 45-degree wedge. You look up the data for that specific wedge, beam energy, and field size, and it tells you the WF is 0.65.
So only 65% of the dose gets through compared to the open beam. If I just use a 150 MU with the wedge, I'd only deliver 65% of the needed dose.
Correct. So to get the full dose, you need to increase the MUS. You calculate 150 divided by 0.65.
150 divided by 0.65. Yeah, let me see. Calculator's out. Okay, that's about 230.77.
Right. And typically in the clinic, you'd round that up to the nearest whole MU, so 231 monitor units.
Wow, quite a jump from 150.
See? You need significantly more MUS when the wedge is in. You're essentially running the machine longer to push enough radiation through that attenuating wedge. That's why the WF is always in the denominator. Dividing by a number less than 1 makes the result bigger.
That makes perfect intuitive sense. Direct compensation. What affects that WF value? Is it just the wedge angle, like 15 versus 45 versus 60 degrees?
The angle is the biggest factor, absolutely. A steeper wedge, like 60 degrees, is physically thicker on average, so it attenuates more, meaning we'll have a lower WF than a shallow 15-degree wedge.
Makes sense. More metal, more blocking.
Right. But beam energy also plays a role. Higher energy photons tend to be more penetrating.
So they might get through the wedge a bit easier.
Slightly, yes. So the WF might be a little higher for a higher energy beam compared to a lower energy beam for the same wedge. Field size can also have a small influence because it changes the amount of scatter generated.
And depth. Does it change much with depth?
Technically, yes. There can be subtle changes with depth due to beam hardening and scatter changes. But for most practical clinical calculations, and certainly for board exam questions, you'll almost always be given a single WF value to use. You can generally assume it applies to your calculation depth unless told otherwise.
Okay, so angle, energy, field size matter, but usually we just get the number to use. Now, you mentioned there was a second, maybe more subtle way wedges affect calculations. Something about effective depth or wedge-in data.
Ah, yes, this is a bit more nuanced. When you put a wedge in the beam, it doesn't just attenuate it uniformly, it actually changes the quality of the beam slightly. Because it's metal, it preferentially absorbs the lower energy photons more than the higher energy ones.
So it filters out the soft stuff?
Yeah.
Makes the beam harder?
Exactly. It hardens the beam spectrum. This hardening, plus the scatter generated within the wedge material itself, means that the way the dose falls off with depth, the shape of your PDD or TMR curve, can be slightly different than for an open beam of the same nominal energy.
Okay, so the depth dose curve itself changes a little.
It can, subtly. Now, some older dosimetry systems, or perhaps very specific data sets, might provide what's called wedge-in PDD or TMR data. This means the depth dose measurements were made with that specific wedge already in place during the measurement process.
Ah, so the data itself already includes the wedge's effect on depth dose.
Correct. If you were using that specific wedge-in data table for your calculation.
Then you wouldn't need to divide by the WF separately.
Exactly right. Because the effect of the wedge on beam quality and attenuation at depth is already baked into the PDD or TMR value you looked up. However,
This isn't the usual way.
no, it's much less common now. The standard practice, and what you absolutely should expect for board exams, is to use the standard wedge out or open field PDD TMR data the table's measured without any wedge, and then apply that separate wedge factor, the WF, in the denominator of your MU calculation, just like we did in the example.
Got it. So the board exam tip is, assume you use open field data and divide by the WF unless the question very specifically tells you you're using wedge-in depth dose data.
Absolutely, that's the default assumption. Use the open field depth dose data and the WF in the denominator.
Okay, that clears that up. What about dynamic wedges? We see those a lot now. No physical block involved there.
Right, dynamic wedges achieve the same goal, tilting the isodose lines, but through a completely different mechanism. It's electromechanical.
How does it work?
Essentially, one of the collimator jaws, usually the upper Y jaw, sweeps across the field while the beam is on. The treatment planning system controls the speed of that jaw movement and sometimes modulates the dose rate as well. By varying how long each part of the field is exposed, it creates that dose gradient.
Clever. So it paints the dose gradient across the field instead of using a physical filter.
That's a good way to put it. It achieves the same dosimetric effect as putting in a physical wedge of a certain angle.
So how does that impact the monitor units? Is there a dynamic wedge factor?
Conceptually, yes. Since the full field isn't open for the entire time the beam is on, the jaw is moving, blocking part of it at any given instant, the effective output is reduced compared to an open field of the same size. The TPS calculation automatically incorporates this. It calculates an integrated factor, sometimes called a dynamic wedge factor or similar, which effectively increases the required monitor units, just like a physical WF does.
But we don't usually calculate that factor by hand.
No, that's handled entirely within the TPS algorithm. It knows the jaw trajectory and dose rate modulation needed for a specific dynamic wedge angle and field size, and it calculates the necessary MUS directly.
Okay, fascinating.
Yeah.
So whether it's a physical block or a moving jaw, the end result is tilted isodoses, and achieving that requires more MUS, accounted for either by dividing by a WF or by an integrated factor within the TPS.
That's the core concept for wedges.
Excellent. Let's shift gears now, moving from modifying a single field to putting multiple fields together. Field matching. This sounds geometrically challenging.
Oh, it absolutely is, and it's clinically crucial. We need to match fields when the target volume is just too big for one field or maybe too complex in shape.
Or when treating different regions that need to connect.
Exactly. Think about matching a supraclavicular field to tangential breast fields. Or the classic example, craniospinal irradiation, matching the cranial fields to the upper spinal field, and then matching sequential spinal fields down the axis.
And the absolute #1 priority has to be managing the dose right there at the junction.
Right, 100%. That junction region is where things can go wrong. You risk either a cold spot, insufficient dose, meaning a potential gap in coverage and risk of recurrence, or a hot spot, excessive dose, leading to potentially severe toxicity or late effects in the normal tissues right at that boundary. Getting uniform dose across the junction is the goal.
Okay, geometry first. My intuition says if I just line up two fields so their edges touch on the patient's skin, that's probably a bad idea because the beams spread out. Divergence.
That's not just a bad idea, it's a recipe for disaster. You've hit the nail on the head. Photon beams diverge, they spread out from the source like a flashlight beam. If you simply abut the field edges on the skin surface...
As they go deeper, they overlap more and more.
Exactly. You get increasing overlap with depth, which means increasing dose. You'll create a potentially massive hotspot deep inside the patient right along that junction line, highly undesirable.
Okay, so don't just bud them together on the skin. The solution must be to leave a gap between them on the surface.
Correct. You need to calculate and set up a specific gap on the skin so that, due to divergence, the edges of the beams meet precisely at your desired depth within the patient.
How do you figure out how big that gap needs to be? There must be a formula.
There is, for the simple case of matching two symmetric, parallel opposed or adjacent fields. The formula calculates the total skin gap, let's call it S, needed between the central axes of the two fields, field 1 and field 2, so their geometric edges meet perfectly at a specific depth below the surface.
Okay, let's hear it.
The total skin gap S is equal to, open parenthesis, the length of field 1 divided by 2 times the depth divided by the SSD of field 1, close parenthesis, PLUS, open parenthesis, the length of field 2 divided by 2 times the depth divided by the SSD of field 2, close parenthesis.
Whoa, okay, let's break that down. L1 and L2. That's the length of the field along the direction of the junction.
Yes, exactly. It's the field dimension parallel to the match line, measured at the source surface distance, the SSD, for that field, SSD1 and SSD2, and D is the specific depth where you want those field edges to meet.
And why L divided by 2?
This is a really critical point. The formula is calculating the divergence of half of each field. Imagine field 1 centered on its axis and field 2 centered on its axis, separated by the gap S on the skin.
Okay.
We want the edge of field 1 closest to field 2 to meet the edge of field 2 closest to field 1 right at depth. The term L12DSSD1 is basically using similar triangles. L12 is the distance from the central axis to the field edge on the skin at SSD1. This term calculates how far laterally that edge has diverged by the time it reaches depth.
Okay, like how much it's moved sideways from the central axis line.
Exactly. And the second term, L22DSSD2, does the same calculation for the edge of field 2. The total gap S you need on the skin is the sum of how much the edge of field 1 diverged towards field 2, plus how much the edge of field 2 diverged towards field 1, all projected back to the skin surface.
Got it. So each L2 term figures out the sideways spread of that half field at depth D, and you add those spreads together to get the total gap needed on the skin, so they just touch at D. That triangle analogy helps.
It really does. Now, a huge board exam tip here. Pay very close attention to how L, the field length, is defined in the question you're given.
What do you mean?
Sometimes L might be given as the full length of the field along the junction. If that's the case, you must divide it by 2 in the formula as we wrote it, L2. But sometimes the problem might give you the half-length directly, maybe calling it W for half-width or something similar. If they give you the half-length, then you don't divide by 2 again in the formula.
Okay. Because the L2 part is already done for you if they give half length. That's a classic way to trip someone up.
Extremely common mistake.
Yeah.
Always double-check if L represents the full length or the half-length.
Let's try a quick example to make this stick. Say field A is 10 centimeters long along the junction, field B is maybe 12 centimeters long, both treated at 100 centimeters SSD. And we want them to match perfectly at a depth D of 5 centimeters. Assume 10 and 12 are full lengths.
Okay, good example. Using the formula S LA2D SSDA plus LB2D SSDB. For field A, 10 centimeter A, 5 centimeters, 100 centimeters, 1.05 equals 0.25 centimeters.
Okay, quarter centimeter from field A's side.
For field B, 12 centimeter to 5 centimeters, or 100 centimeters, or 6 centimeters, 0.3 centimeters, 0.3 centimeters from field B's side.
So the total required skin gap S between the central axes is 0.25 centimeters plus 0.30 centimeters equals 0.55 centimeters.
Just over half a centimeter gap on the skin ensures those diverging edges meet exactly 5 centimeters deep. Okay, that makes the formula much clearer.
It's all about accounting for that divergence. Now, that calculation works for making two diverging fields meet nicely. But what if you don't want divergence at the match line at all? What if you want a perfectly straight geometric match line at depth, with one field edge having zero divergence into the adjacent field's territory?
How can you get a zero divergence edge from a beam that naturally diverges? You have to manipulate the collimation. You create what's called a non-divergent or monoaxial field edge. The trick is to set one of the collimator jaws so that its edge lies exactly on the beam's central axis.
At a jaw position to zero.
Precisely. If a jaw is set at the zero position, it lies directly under the radiation source along the central axis line. Any point along that jaw edge is essentially seeing the source directly above it, in line with the central axis. The field edge defined by that jaw will then be geometrically parallel to the central axis as it goes down into the patient. It has zero geometric divergence.
Okay. Because the rays defining that edge all originate from the source and pass through a line, jaw edge, that's directly below the source. They travel parallel to the central axis. Clever.
It is, and you can achieve this in a couple of ways. Older techniques might use a physical half-beam block, which is literally a lead block shaped so its edge aligns perfectly with the central axis.
Like blocking half the beam.
Oh, exactly. But much more commonly now, with modern Linux that have independent or asymmetric jaws, you simply drive one of the jaws to the zero position using the computer control.
So asymmetric jaws set to zero give you that non-divergent edge. How does this tie in with rotating the collimator or the treatment couch?
You often combine these techniques. For instance, in craniospinal irradiation, you might set the inferior jaw of the cranial field and the superior jaw of the spinal field both to zero, non-divergent. Then you'd rotate the collimator for the spinal field so that its non-divergent edge perfectly aligns with the non-divergent edge of the cranial field.
Okay, so collimator rotation helps align those edges. What about couch kicks?
Couch rotation, or couch kicks, are often used, especially when matching fields that aren't nicely parallel, like matching tangential breast fields to a supraclavicular field. The supraclavicular field might have a straight inferior border, maybe non-divergent, while the tangential fields have diverging superior borders. You might use a couch kick for the tangential fields to help align their diverging superior edges with the inferior edge of the supraclavicular field, often in combination with asymmetric jaws on the tangents as well.
So it's a whole toolbox of geometric tricks. Skin gap calculations for simple divergence matching, or using zero jaw half-beam blocks, sometimes combined with collimator or couch rotations, to create these clean, non-divergent match lines.
Exactly. The goal is always geometric precision at the depth you care about. But here's the kicker. Even if you achieve perfect geometric alignment, getting truly uniform dose across that junction is still incredibly difficult.
Why? If the geometry is perfect, shouldn't the dose just add up smoothly?
You'd think so, but physics gets in the way. There are several dosimetric factors that mess things up at the junction. First, there's penumbra.
The fuzzy edge of the beam.
Right. Radiation field edges aren't infinitely sharp knife edges. You have geometric penumbra because the radiation source isn't a perfect point source, it has a finite size. And you have transmission penumbra because some radiation leaks through the very edges of the collimator jaws or blocks. This means the dose doesn't drop from 100% to 0% instantly at the geometric edge. It falls off gradually over a few millimeters.
Okay, so even where the geometric edges meet, there's already a bit of a dose gradient, not a sharp line.
Correct. But often the bigger problem, especially for creating hotspots, is scatter.
Radiation bouncing around inside the patient.
Exactly. When the primary photon beam interacts with tissue, it creates scattered photons and electrons that travel in different directions. This scattered radiation doesn't respect the neat geometric field boundaries nearly as well as the primary beam does.
So scatter from field A can spill into the region of field B at the junction and vice versa.
Precisely. You get scatter contributions from both adjacent fields landing right in that junction zone. This can significantly boost the dose right where the fields come together, potentially creating a hotspot, even if your geometric alignment using primary beam edges was perfect.
Wow. Okay. Scatter is the enemy of clean junctions.
It's a major challenge. And you also have to consider things like field horns.
Horns.
Yeah, due to the design of the flattening filter used in most medical Linux, there are often regions of slightly higher dose near the edges of the field, particularly at shallower depths. These horns can also contribute to dose inhomogeneity at the junction if they overlap.
So perfect geometry gets you close, but then you're battling penumbra, scatters from both sides, and maybe even field horns, all potentially messing up the dose right at that critical boundary.
That sums it up pretty well. It highlights why achieving truly seamless dose across a match line is so challenging and why careful dosimetry is needed. Modern TPS algorithms put a lot of effort into modeling scatter accurately, especially near interfaces and junctions.
It gives you appreciation for what the TPS is doing behind the scenes. Clinically, then, if it's so hard to get perfect, how do we manage the risk of these hot or cold spots?
Beyond just planning carefully, one very common clinical technique is called feathering the junction.
Feathering, like smoothing it out.
Kind of. It involves deliberately moving the position of the match line slightly between treatment fractions, or maybe every week.
Ah, so you don't treat the exact same junction line every single day.
Exactly. Maybe for 1 week the match line is at position X, the next week it's shifted slightly superiorly to X plus 1 centimeters, and the week after maybe slightly inferiorly to X minus 1 centimeters before cycling back.
Why do that?
If there is a small residual hot spot or cold spot right at the junction despite your best efforts, feathering helps to blur that dose variation over a slightly larger volume of tissue across the entire treatment course. Instead of concentrating a potential overdose or underdose along one fixed line fraction after fraction, you average it out a bit. This reduces the risk of severe localized toxicity from a hot spot or a geographic miss from a cold spot.
That's a really clever, practical way to mitigate the inherent uncertainties. So field matching. It's this complex dance between precise geometric setup using skin gaps or non-divergent edges and rotations, and then managing the dosimetric realities of penumbra and scatter, often using techniques like feathering to smooth things out clinically.
An excellent summary. It's a blend of geometry and dosimetry.
Okay, let's change gears completely now. Electron beams. These just feel different from photons, right? Mainly because they actually stop in tissue, that finite range.
Fundamentally different, yes.
Yeah.
Different particles, electrons versus photons, leading to different interactions and very different dose distributions. Electrons are charged particles. They deposit energy directly through collisions as they travel. And yes, that finite range is their defining characteristic. They penetrate tissue up to a certain depth, deposit their dose, and then they essentially stop. The dose drops off very, very sharply.
And that sharp drop-off is why they're so useful for superficial targets.
Absolutely. If you have a target right on the skin surface, or maybe just a centimeter or two deep, think skin cancers, boosting electron boost fields for breast cancer, treating lymph nodes close to the surface, chest walls, post-mastectomy, electrons are often ideal.
Because you can hit the target with a good dose.
You can deliver a high uniform dose to that superficial region, and then because of that rapid dose fall-off, you significantly spare the deeper normal tissues and critical organs that might lie just beyond the target. Think heart, lung, spinal cord.
What does the depth dose curve actually look like compared to a photon beam?
It's quite distinct. High-energy photons, as you know, have that build-up region near the surface, skin-sparing, then Dmax, then a gradual, almost exponential decrease in dose with depth. Electrons are different. They typically have a high surface dose. Then the dose builds up rapidly to a maximum Dmax at a relatively shallow depth. After Dmax, there's often a region where the dose stays relatively high and flat, or maybe slopes gently downwards, followed by a very sharp, almost cliff-like decrease in dose. Beyond this steep fall-off region, the dose drops to near zero very quickly. There's usually a small tail of dose beyond the main fall-off, which is due to Bremsstrahlung X-rays produced as the electrons slow down in tissue, but the useful treatment dose effectively stops. The depth where this practical dose ends is called the practical range, R sub p.
And you mentioned high surface dose. So unlike high-energy photons, electrons don't really spare the skin.
Correct. They generally deliver a significant dose right at the surface, typically somewhere between 70% and 95% of the maximum dose, depending on the electron energy and the field setup. This high surface dose is often desirable if the target includes the skin itself.
And if you need an even higher surface dose, or if the surface was uneven.
That's where bolus comes in. You can place a layer of tissue-equivalent material, the bolus, directly on the skin. This effectively shifts the entire depth dose curve more superficially, bringing the high-dose region right up to or even onto the skin surface. It also helps create a flat surface for the beam to enter, ensuring a more uniform dose distribution when dealing with irregular patient contours.
Okay, so unique depth dose, high surface dose, finite range. How do we calculate monitor units for electrons? Is it the same big formula we use for photons with all the factors?
The formula looks simpler, actually, which can sometimes be a bit deceptive. It has fewer named factors explicitly listed, but some of those factors are doing more work behind the scenes. The biggest difference from photons lies in how we handle scatter.
Scatter is different for electrons.
The way scatter influences the output is very different and highly dependent on the geometry right near the patient surface. Specifically, it depends heavily on the size and shape of the electron applicator or cone that shapes the beam, and any custom lead or alloy cutouts placed within that cone to define the final field shape.
Why is the cone size so critical for electron scatter compared to photons, where we think more about collimator setting and depth?
It's because electrons scatter much more readily and through different mechanisms, primarily Coulomb interactions with atomic electrons and nuclei. A significant amount of scatter relevant to the dose output comes from electrons scattering off the inside surfaces of the applicator walls and the edges of the cutout.
So the cone itself is a major source of scatter into the treatment field.
Exactly. A larger cone generally produces more scatter contribution than a smaller cone, which increases the dose rate or output at Dmax. With photons, we separate scatter effects into collimator scatter, SC, and phantom scatter, SP. For electrons, we don't do that. Instead, we use a single factor, usually called the cone output factor, or sometimes just output factor.
So this one factor covers all the scatter.
Essentially, yes. This cone output factor is measured experimentally for each standard cone size, and often for commonly used cutout shapes within those cones. It inherently incorporates all the scatter contributions from the Linac head, the cone, and the cutout for that specific setup. It's typically normalized to the output of a standard reference cone, like a 10 by 10 or 15 by 15 centimeter cone.
Okay, so the cone output factor bundles up all the geometry-specific scatter effects near the surface, doing the job that Zag and Hess knew for photons, but tailored to the electron kind of cutout setup.
That's a perfect way to describe it. Now, the other factor we need to consider is the inverse square law. Does it apply to electrons?
Good question. Does it?
Yes, it does apply, but again with a twist. Because of all the scattering that happens, not just in the cone, but also in the air between the source and the patient, the electrons don't appear to diverge perfectly from the physical radiation source, the target or scattering foil.
So the source looks like it's somewhere else.
Effectively, yes. We use the concept of an effective source position, or more practically, an effective source surface distance, SSD effective. This effective SSD is determined experimentally, usually by measuring output at different distances, and it's slightly different from the nominal physical SSD. Importantly, this effective SSD can vary depending on the electron energy and sometimes even the applicator size.
Okay, so if I'm treating at the standard SSD where the machine was calibrated and the output factors were measured, do I need an inverse square correction?
No. If you treat at the standard SSD, your example 100 centimeters, the output factor already accounts for the dose rate at that distance. But if you have to treat at an extended SSD, maybe the patient setup requires a larger gap between the cone and the skin.
Like if there's bulky anatomy in the way.
Exactly. If you treat at, say, 105 centimeter SSD instead of a 100 centimeter SSD, then you do need to apply an inverse square correction factor, just like you would for photons, but you must use the effective SSD in the calculation.
How do you calculate that inverse square factor, ISF, using the effective SSD?
The full formula for the correction factor to apply at the calculation point depth D is the square of S effective plus D cal divided by the square of S effective plus G plus D. Here, D cal is the depth of calibration, usually Dmax for electrons. G is the air gap between the standard SSD and the actual treatment SSD. So treatment SSD equals standard SSD plus G, and D is the depth of the calculation point.
That looks a bit complicated. Is there a simpler way?
Often, especially since Dmax for electrons is usually quite shallow, a simpler approximation is used, particularly if you're calculating dose at or near Dmax. You can approximate the ISF as the square of S ist effective plus Dmax skull, divided by the square of S ist effective plus G plus Dmax treat, or even simpler for quick estimates, just use the square of S ist effective divided by the square of S ist effective plus G. The key point is you must use the effective SSD value provided for that energy applicator, not the nominal 100 centimeter SSD.
Got it. Use effective SSD for off distance corrections. Okay, let's put it all together. What's the full monitor unit formula for electrons?
It's generally simpler in structure than the photon one. Monitor units, MU, equals the prescription dose, Rx dose, divided by the product of several factors in the denominator.
Okay, what's in the denominator?
It's Rx dose, CAL factor, cone output factor, percent depth dose, inverse square factor, if applicable.
Let's quickly define those again in the context of electrons.
Sure. Rx dose is your target dose, often prescribed to Dmax or maybe the 90% or 80% oscillose line depth. CLL factor is the calibrated output under reference conditions, typically defined as 1.0 cgMu at Dmax for a specific reference cone, AG 10 by 10 at the standard SSD.
Okay, the baseline calibration.
Cone output factor, RSF, is the factor we just discussed. It corrects the output for the specific treatment cone and cutout you're using relative to that reference cone.
Accounts for the specific scatter.
Percent depth dose, PDD,
Yeah.
the PDD value at your calculation depth specific to the electron energy, cone size, and cutout shape you're using.
And the inverse square factor, ISF.
Is that correction factor we just calculated using the effective SSD, but it's only needed if you're treating at an extended SSD, i.e. G0. If you're at the standard SSD, the ISF is just 1.0.
All right, let's try the example from the source material to make sure this clicks. Prescription is 200 centigrade, 200 Cg, delivered to a depth corresponding to the 90% adobose line.
Okay, Rx dose equals 200 Cg.
The machine calibration CAL factor is 1.0 centigrade per mu, 1.0 cgMu at Dmax for the reference cone.
CAL 1.0.
The cone output factor for the specific cone and cutout being used is 0.95.
To 1.95.
The PED, its prescription depth, the 90% line is, well, 90%, which is 0.90 as a decimal.
PED equal 190.
And let's assume we're treating at the standard SSD, so no air gap.
Okay, so ISF 1.0. Now we plug these into the formula. MU equal Rx dose, CAL of PDD ISF.
So MU is 200, 1.0, 0.95, 0.95, 0.90, 1.0.
Right, first calculate the denominator. 1.0, 0.95, 0.90, 1.0. That's just 0.95 times 0.90.
0.9 5 times 0.90. That's 0.85, 0.855.
Correct. So MU equals 200, 0.855.
200 divided by 0.85.
Yeah.
Calculator again. Gives approximately 233.9, 233.9.
Exactly. And you'd round that clinically probably to 233 or 234 monitor units.
So while the formula looks simpler, fewer terms maybe than the full photon one, that cone output factor is doing a ton of work, wrapping up all those complex scatter conditions specific to the applicator and cutout.
Precisely. Getting that cone output factor right for your specific setup is absolutely critical for accurate electron MU calculations.
Got it. Simpler formula structure, but don't underestimate the importance of that cone factor.
You got it.
All right, last major calculation area for this session, tissue inhomogeneity corrections. The source material rightly points out patients are definitely not made of water.
No, they are not. And ignoring this fact can lead to significant errors in dose delivery. The human body is a complex mix of tissues with vastly different physical properties, especially density. Think about low-density lung, high-density bone, air cavities, fat, muscle, all different from water.
Why does density matter so much for how radiation travels and deposits dose?
Because the fundamental interactions of radiation with matter, both absorption and scatter, depend very strongly on the density of the material, specifically the electron density, how many electrons there are per unit volume. And for lower energy photons, the atomic number Z also plays a significant role, especially for photoelectric absorption.
So if the beam goes through something that's not water equivalent, the standard calculations assuming water will just be wrong.
They will be inaccurate, yes, sometimes significantly so.
Let's take lung. It's much less dense than water or soft tissue, right? Mostly air.
Exactly. Lung tissue has a much lower electron density. So as a photon beam passes through a section of lung, it encounters fewer electrons to interact with per centimeter traveled. This means it undergoes less attenuation. Fewer photons are absorbed or scattered out of the beam path compared to if it had passed through the same physical thickness of water.
Less attenuation means more photons get through the lung.
Correct. Which means the dose delivered to the tissues beyond the lung will be higher than your water-based calculation predicted.
Okay, lung lets more radiation through, increasing dose downstream. What about the opposite, like bone?
Bone, especially dense cortical bone, has a significantly higher physical density and electron density than water. It also has a higher average atomic number. So when a beam passes through bone, it undergoes more attenuation.
More interactions, more absorption, and scatter.
Yes. Fewer photons make it through the bone compared to the same thickness of water. Therefore, the dose delivered to tissues beyond the bone will be lower than a simple water equivalent calculation would suggest.
That's a really critical concept.
Yeah.
Lung increases dose beyond it relative to water. Bone decreases dose beyond it relative to water.
Memorize that relationship. It's fundamental to understanding inhomogeneity effects.
Does it affect scatter within the inhomogeneity too?
Yes, definitely. In low-density lung, there's less tissue to generate scatter, so the scattered dose component within and near the lung might be lower. In high-density bone, especially with lower energy photons where the photoelectric effect is more prominent, which depends strongly on Z, you can get increased scatter. These changes in scatter also influence the dose distribution.
And what about right at the edges, the interfaces?
That's another important effect, especially for electrons and lower energy photons. At the interface between two tissues of different densities, like soft tissue and lung, or soft tissue and bone, the balance of charged particles, electrons moving across the boundary, is disrupted. This is called a loss of charged particle equilibrium, CPE. It can lead to dose perturbations, typically an underdosing on the low-density side and a slight overdosing on the high-density side, right near the interface, over a distance related to the range of the secondary electrons.
Okay, so inhomogeneities mess with attenuation downstream, scatter within, and dose right at the boundaries. How do we actually correct for this in calculations, especially for, say, board exam type problems or basic checks?
Well, modern treatment planning systems use very sophisticated algorithms. They take the 3D density information directly from the patient's CT scan and use algorithms like convolution superposition or Monte Carlo simulations to model the radiation transport through all the different densities very accurately.
But for hand calculations or understanding the basic principle.
For that, the most common and fundamental method to learn is the effective depth or radiological path length, RPL method.
RPL, okay.
The basic idea is pretty intuitive. We want to figure out, for a given physical thickness of an inhomogeneity, like lung or bone, what thickness of water would cause the same amount of primary beam attenuation. We're essentially converting the path length through the real tissue into an equivalent path length through water.
Finding the water equivalent thickness.
Exactly. And the conversion factor we use is the electron density of that tissue relative to water.
Why electron density specifically?
Because for the high-energy photons typically used in radiation therapy, the dominant interaction process is Compton scattering. And the probability of Compton scattering is directly proportional to the electron density of the material. While other interactions matter, especially photoelectric effect in bone at lower energies, electron density is the primary driver of attenuation differences for megavoltage beams in most tissues.
Okay. Does the source material give us some typical values for these relative electron densities?
Yes, and it's good to have a few key ones memorized. By definition, water and most soft tissues are considered to have a relative electron density of 1.0. Air is very close to 0, maybe 0.001, often just treated as 0 for rough calculations.
What about the important ones, lung and bone?
For lung, because it's mostly air, the relative electron density is much lower than water, typically around 0.25, 0.25, maybe up to 0.3, depending on inflation. For dense cortical bone, it's significantly higher than water, around 1.6 to maybe 1.8. For board exam problems, lung euro 0.25 and bone at 1.65 are very common values to see and use.
Okay, memorize. Lung about a quarter, bone about 1.65 relative to water being 1.0. So how do I use these numbers? If my beam goes through 10 centimeters of lung.
You calculate the radiological path length, RPL, for that lung layer. You take the physical thickness, 10 centimeters, and multiply it by the relative electron density of lung, 0.25.
So 10 centimeters, 0.25 equals 2.5 centimeter.
Exactly. That 10 centimeters of lung only attenuates the primary beam as much as 2.5 centimeters of water would. Now, if your beam passes through multiple different tissue layers before reaching your point of interest,
Like tissue, then lung, then more tissue.
right, you calculate the RPL for each layer separately, physical thickness of layer 1 times relative density of layer 1, physical thickness of layer 2 times relative density of layer 2, and so on. Then you sum up all those individual RPLs.
And the total sum is the effective depth in water.
Yes, that sum is the total radiological path length. It represents the single thickness of water that would provide the same total primary beam attenuation as all those different layers combined. You then take this total RPL value, this effective water equivalent depth, and use it to look up your PDD or TMR value from your standard water-based depth dose tables.
Ah, so instead of using the actual physical depth to the point, I use this calculated RPL as the depth in the tables.
Precisely. And that PDD or TMR value based on the RPL is what you plug into your monitor unit calculation.
Let's try the example from the source to make this concrete.
Right.
A photon beam goes through 5 centimeters of soft tissue, relative density 1.0, then through 8 centimeters of lung, relative density 0.25, to reach a target point. What's the RPL to the target?
Okay, step by step. First layer, 5 centimeters of soft tissue, RPL.
Yeah.
Physical thickness, relative density at 1.0 is 5 centimeters.
Easy enough. Water equivalent tissue just contributes its own thickness.
Second layer, 8 centimeters of lung, RPL. Physical thickness, relative density equals 8 centimeters, 0.25.
8 times a quarter. That's 2 centimeters.
Correct. The 8 centimeters of lung is equivalent to only 2 centimeters of water in terms of attenuating the primary beam.
So the total RPL to the target is the sum of these.
Yes. Total RPL, OPL tissue plus RPL lung plus 5 centimeters plus 2 centimeters plus 7 centimeters.
So even though the target is physically 5 plus 8 equals 13 centimeters deep, for calculation purposes using water tables, its effective depth is only 7 centimeters.
Exactly. And think about what that means. When you look up a PDD or TMR at 7 centimeter depth, it will be a higher value than if you looked it up at 13 centimeters depth, since dose decreases with depth. Using this higher dose factor correctly accounts for the increased dose transmission through the low-density lung.
That makes perfect sense. The calculation automatically reflects the increased dose. Okay, let's quickly flip the lung to bone. Same setup, but 5 centimeter tissue, then 8 centimeters the bone with relative density 1.65.
Okay, tissue RPL is still 5 centimeter 1.0 accords 5 centimeters. Bone RPL 8 times 1.65.
8 times 1 is 8. 8 times 0.6 is 4.8. 8 times 0.05 is 0.4. So 8 plus 4.8 plus 0.4 plus 0.4 is 13.2 centimeters.
Spot on. The 8 centimeters of bone is equivalent to 13.2 centimeters of water attenuation.
So the total RPL is 5 centimeter tissue plus 13.2 centimeter bone equals 18.2 centimeters.
Right. Now, the physical depth is still 13 centimeters, but the effective radiological depth is 18.2 centimeters.
And using 18.2 centimeters in the depth dose tables will give me a lower PDD TMR value compared to 13 centimeters, correctly predicting the decreased dose transmission through the dense bone.
You've got it. That's the power and the core concept of the RPL method.
Are there other methods mentioned, like ratio of TMRs or Bethe power law? Are they just more complicated ways of doing the same thing?
They are generally older or slightly more refined analytical methods. The ratio of TMRs method, for example, implicitly uses the RPL concept within its formulation. The Bethe power law tries to account for scatter differences as well. But for understanding the fundamental principle and for tackling most basic calculation problems, the RPL method using relative electron density is the key one to master.
So RPL and remembering lung ebb 0.25, bone ebb 1.65 is the main takeaway for basic inhomogeneity corrections.
Absolutely. And understanding this principle is crucial even when you're relying on a sophisticated TPS, because it helps you anticipate how dose distributions should look when beams pass through different tissues and to sanity check the computer's output. Getting these corrections wrong can lead to clinically significant errors, potential overdosing of normal tissues like lung or spinal cord beyond lung, or underdosing the tumor if it's behind bone.
That really underscores the importance. Okay, wow, that was a lot of calculation detail, but incredibly important stuff. Let's try to boil down the absolute must-remember points into some clinical pearls.
Great idea. Let's crystallize the takeaways. Pearl number 1, wedges. For MU calcs with a physical wedge, always divide the open field MUS by the wedge factor WF-MUS go up.
Pearl number 2, field matching. For symmetric diverging fields, calculate the skin gap S using S L12D SSD1 plus L22D SSD2. Watch out if L is full or half length. For straight match lines at depth, use non-divergent edges created by zero jaws or half-beam blocks, often combined with collimator or couch rotations.
Pearl number 3, electrons. MU calc is dose, CAL cone of PDD ISF if needed. That cone output factor is key. It bundles scatter for your specific kind of cutout. Remember to use the effective SSD for inverse square corrections if you're treating at an extended distance.
And pearl number 4, inhomogeneities. Use the radiological path length, RPL method. RPL for a layer equals its physical thickness times its relative electron density. Sum the RPLs of all overlying layers to get the total effective depth. Use that effective depth in your water tables. Key densities: lung air 0.25, bone air 1.65.
Those 4 really hit the highlights of what we covered.
Feeling sharp? Ready for a quick board review blitz to see how well these stuck?
Let's do it. Fire away.
All right, question 1. An open field requires 150 monitor units. If a 45-degree wedge with a wedge factor of 0.65 is inserted, how many monitor units are needed to deliver the same dose to the calculation point? Is it A, 97.5 mu, B, 150 mu, C, 215 mu, or D, 231 mu?
Okay, wedge factor problem. Mu with wedge equal mu open WF. So 150, 0.65. We calculated that earlier. It was about 230.77. So the closest answer is D, 231 monitor units.
Correct. D it is. Question 2. To geometrically match two symmetric photon fields, field A, length LA at SSDA, and field B, length LB at SSDB, on the skin, so at depth D, the required skin gap between central axes is approximately. Okay, the options are formulas. Option A has LSSDD terms. Option B has LDSD terms, but without dividing L by 2. Option C is LA2D SSDA plus LB2D SSDD. Option D says the gap is 0 because it requires collimator rotation.
Right. This is the skin gap formula. We need the sum of the half-field divergences projected to the skin. That matches option C, L2D SSD for each field added together, assuming LA and LB represent the full field length. So the answer is C.
Excellent. Option C is the correct formula. Question 3. Electron beam treatment. Prescribe dose 200 Cg to the 90% acidose line. CAL equals 1.0 cgmu. Specific cone output factor is 0.95. The PDD at the prescription depth 90% line is 0.90. What are the MUS needed? A, 200 mu, B, 211 mu, C, 222 mu, or D, 233 mu. Assume standard SSD.
Okay, electron mu dose CLO of PDD. So 1.0, 0.95, 0.9. The denominator is 0.855, so 200.855. We also did this calculation as 233.9, so the answer is D, 233 monitor units.
Perfect. D is correct again. Final one, question 4. A photon beam passes through 5 centimeters of soft tissue, relative electron density 1.0, and then through 8 centimeters of long, relative electron density 0.25 to reach a target. What is the radiological path length, RPL, to the target? A, 7 centimeters, B, 10 centimeters, C, 13 centimeters, or D, 15 centimeters? The answer is layer 1, tissue, 5 centimeters to 1.0, layer 2, lung, 8 centimeters or 0.25, 0.25 is below 0.2 centimeters RPL. Total RPL sum equal 5 centimeters plus 2 centimeters. The answer is A.
Fantastic. A, 7 centimeters is correct. Great run through the blitz. It really does help cement those formulas and concepts. It does. And honestly, while these calculations might seem daunting at first, they are definitely manageable with practice. My best advice: always try to draw a picture first, especially for the geometry ones like field matching or inhomogeneities. Sketch it out.
Visualize the setup.
Exactly.
Yeah.
Label your distances, your tissues, write down the variables you know, then pick the right formula. And just be careful plugging in the numbers, watch your units. But more than just plugging numbers, really try to understand why the formula is the way it is. Why is WF in the denominator? Why does RPL use relative density? That understanding prevents so many simple mistakes.
The why is definitely the key to making it stick, not just rote memorization. And yeah, diagrams are lifesavers.
They really are. You know, it's funny, trying to remember all these specific formulas, like right after you take your physics boards, it feels a bit like trying to remember where you parked your car after you've been on call for 24 hours straight. Just think, why do I need to keep this in my head? The TPS knows the way. Just kidding. Well, mostly. Understanding the principles is always key.
That's a perfect analogy. And you're absolutely right. The humor points to the serious reason why understanding matters. Even though the TPS does the heavy lifting for complex plans, your grasp of these fundamental principles, how wedges work, how beams diverge, how tissue density affects dose, that's your built-in quality assurance check.
Exactly. It's what allows you to look at a plan and say, does that isodose distribution through the lung actually look right? Or is that junction dose reasonable? You need that intuition grounded in physics.
That's the difference between just using a tool and truly understanding how it works, which is essential for patient safety.
Well said. That's the goal.
So just to quickly recap our calculation deep dive today, we hit physical and dynamic wedges remembering MUS increase divided by WF. We covered field matching geometry, skin gaps, non-divergent edges, rotations, and the dosimetric hurdles of penumbra and scatter. We looked at electrons, their unique depth dose, the crucial cone output factor, effective SSD for ISQ corrections, and finally, tissue inhomogeneities using radiological path length, RPL, thickness rel density, to find effective depth, especially for lung and bone.
Mastering these areas is just fundamental, foundational for good practice.
So here's a final thought to leave you with. As you go back to clinic or continue studying, consider how your understanding of these basic, sometimes even hand-calculable principles provides the critical intuition you need. How does knowing the why behind these formulas help you evaluate the complex output of a modern TPS and ultimately ensure you're delivering the safest, most accurate treatment possible for your patients?
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next session. Thanks for tuning in.